everyone, and welcome to my YouTube channel, Pain Free Partha. Today we are going to talk something differently, maths and physics of blood pressure, part 1. And I'm thankful to this institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry, and the legendary teacher of 2 centuries, Professor Ravi Shankar. What is blood pressure and why do we need to measure it? Pressure is defined as a force per unit area. The SI unit is Pascal. What is it? Force per unit area. Okay, is commonly expressed in manometric unit, millimeter of mercury, which measures pressure from the height of a column of mercury in a manometer. That is what is measured at, millimeters of mercury. So now, if you say 120 millimeters of mercury, the absolute pressure is 760 plus 120, that is 880. Now, if you say 120 millimeters of mercury, it means 120 above the atmospheric pressure. That is 880 absolute, but we don't tell and confuse. The systolic blood pressure, how is it generated? It is a force of myocardial contraction. The heart is a series of curved surfaces. And now you see the heart is a curved surface. Now there is a tension developed in the wall, the pressure inside the cavity, the radius. These are the things which defines. Now what is the pressure inside? That is 2T by R, 2 into tension divided by R. So tension radius, that is what is called the Laplace law. Now what happens in systole here, as soon as the heart contracts, the mitral valve closes and it reaches the pressure of 126 or 128. The aortic valve opens and it is jetted. The pressure rises as the radius remains the same. Aortic valve opens and then the pressure develops. The pressure generated is significantly, if you increase the radius here, 2T by R, now R is increased, pressure will be decreased. That is why sometimes the dilated cardiomyopathy leads to heart failure because it cannot push in so much of blood pressure. For this, something else may happen. For example, the systemic vascular resistance may increase and to compensate for it. We will go later. But radius is increased, pressure is decreased. Okay, that is very simple. If the tension remains the same. Now there are pumps here. You can see the nozzle, the low pressure jet, the high pressure jet if it comes from kilo. Conventionally performed on the arm, which roughly equates to the right atrium, what we call as phlebistostatic axis. I will come to this later, this phlebistostatic axis, when I get the maths and physics of blood pressure, part 2. Okay. The systolic blood pressure refers to impulse pressure, which moves with each stroke volume into the blood. It may be either pulmonary or systemic. The systolic pressure of pulmonary is 25, while the systemic is 120. Now it is generated by ventricular systole. But what is diastolic pressure? It is a pressure within the arterial system. There are two things in this: the tone of the arterial resistance and the compliance of the vessels. Why diastolic blood pressure is important? DPP is because coronary perfusion takes place to the brain. What are the two things? Compliance and tone. Normally, there are two types of arteries, muscular and elastic. The elastic stretches and smoothens the flow. This is called Wien-Kessel effect. When the elastin decreases, the smoothing is gone. The compliance decreases. Now, the difference between systolic and diastolic pressure is called pulse pressure. Now, 120 by 80, pulse pressure is 40. 160 by 80, pulse pressure is 80. The difference between systolic and diastolic. A change in the pulse pressure is proportional to the volume change, but inversely proportional to the compliance. Now, the pulse pressure is equal to stroke volume by compliance. That is the pulse pressure. If the compliance is high, pulse pressure is low. If the compliance is high, that is, stroke volume is okay, 80 ml. The compliance is high, that is 4. Then the pulse pressure is 40 by some 60 by 4 or 80 by 4. It is only 22 or 23. 80 by 4 stroke volume, right? If the compliance is 2, stroke volume by compliance 2. What is the compliance? It is, I'll tell you, 80 ml, an arterial compliance of 2 ml per Hg, a normal pulse pressure of 40. Change in the volume over a change in the pressure. Okay, this is what is called the compliance. How much ml? For example, normal compliance of a lung. So 500 ml has to go. Okay, if it has to go within so much time and this thing. For example, now you tell this is the balloon. Now, if you like that, the volume changes. The pressure does not increase much in a good compliant balloon. Okay, good compliant balloon, the pressure does not change. If the balloon is not that compliant, the volume 100 ml will make the pressure very high. This is what is the delta P by delta V. Pressure and compliance. Now, lung compliance is delta V by delta P. A pulse pressure that is less than 25% of the systolic pressure is inappropriately low, and 100 is more than. Widened pulse pressure is in mitral regurgitation and aortic regurgitation. It may be the BP may be 140 by 40. That you think of old age or MR or AR. Narrow pulse pressure aortic stenosis, sometimes due to cardiac tamponade or heart failures. That is what is the narrow pulse pressure. Aerobic exercises increases the compliance. The vessels becomes better. Now we know what is pulse pressure. 80 by 2. What is 80? Stroke volume. What is compliance? 2, 40. That is different. Pulse pressure is what? 120. Systolic, diastolic is 80. 120 minus 80, 40. How does this 40 comes? How does this 40 comes? Stroke volume. It's not diastolic pressure. Stroke volume is 80 ml. Divided by compliance is 2. That is 40. Okay. Now we go to mean arterial pressure. Mean arterial pressure is the average pressure throughout the cardiac cycle. This is what we want. Key determinant of perfusion, cerebral, renal, everything. We want an MAP. Map. You just keep the map above 55. You can keep the map above 65. This is what usually told. Because throughout the cardiac cycle, what is the mean pressure? So we need good perfusion to the liver. We need good perfusion to the kidneys. We need good perfusion to the brain. So that is systolic blood pressure. By 1/3 of the difference by systolic. Now we keep diastolic is 80. 1/3 of 40. 1/3 of 40 is around 13. So 40 plus 13 is 53. That is the right. You can also calculate in a different way. 1/3 of pulse pressure. Why is? Because a typical resting rates, systole is 1/3 of the cardiac cycle. Diastole is 2/3. That is why we are doing this 1/3 business. Diastole is 2/3. That is why it is calculated as 1/3. Okay. Because we cannot, that is why it is very important. If you calculate this way, if the diastolic time shortens at a heart rate of 110, then this may be doubtful. Machine calculates the area under the curve. MAP is 2 diastolic pressure plus SBP divided by 3. So 2/3 of diastolic plus SBP by 3. So now you see systolic arterial pressure. This is the mean arterial pressure. This is the diastolic pressure. Pulse pressure is 40, 120, 80. Now area under the curve divided by cardiac cycle time. This is how a machine calculates the MAP. Area under the curve divided by cardiac cycle time. 1 second, 1.2 seconds, something like that. So that is how it calculates the MAP. What is Ohm's law? Ohm's law is equal to voltage is equal to current into resistance. This is what is Ohm's law. Current into resistance is equal to voltage. Now you keep voltage as pressure, current is cardiac output, R is SVR. Okay, this Ohm's law comes here. MAP is equal to cardiac output into SVR. Okay. MAP cardiac output is equal to normally 5 liters. SVR is 1500. So it may be 5 into 115 or something like that. 75 if it comes. Or if it comes 5 into 750, 70.5, something like that. Okay. It comes to this. It has to be in equal units. If you calculate here resistance as dynes and here has to be pressures. Now you see the left heart is pumping here, the capillary systems into the lungs, the right heart into the lungs. And again, this is not as this. Pipelines are not as rigid as thick. It is like this. The curves are not like this. Measurements, there are so many things, so many gauges were kept how to measure blood pressure in the history. Now, if we take a routine blood pressure monitor, we need to measure the monitor cuff, brachial artery, here stethoscope position and all. There are how now you see non-invasive and invasive. Non-invasive is intermittent sphygmomanometers, auscultatory method, mercury and aneroid. Oscillometric methods that we use is dynamap and Walker-Klinghofen's oscillotonometers. Non-invasive sphygmomanometers, auscultatory method, mercury, aneroid. Oscillometric, dynamap. This is what we use mostly. Now, if you go to other things, it may be continuous. What we see in the monitor is intermittent. Intermittent, sphygmomanometer, oscillatory methods, dynamap. This is what we use. Sometimes we just keep a finger above phenopress and it determines continuously, but it is non-invasive. We have not put any arterial line. We have not put any plastic into the radial artery, but it is continuously measuring the blood pressure. But that is phenopress technique or radial arterial compression. This is continuous, this is intermittent. Now there may be arterial line, central line, Sandgren's catheter, which can measure direct continuous. Now we go to non-invasive intermittent. That is what is called sphygmomanometers. Inflatable pneumatic fitness. You have to have an adjustable valve to release the pressure. You have to have a pressure gauge. Either it is mercury or aneroid. You have to have a method of identifying the systolic and diastolic. For example, Korotkov's methods or oscillation. Now, sphygmas, the beating of the heart or the pulse, manometer is the device. So, beating of the heart plus manometer is what is called sphygmomanometer. It's very simple, connected to the blood pressure curve, open to atmosphere. Pressure is equal to density into acceleration due to gravity into height. 1 kPa will support 10.2 centimeter of water or 7.5 millimeter of mercury. So pressure is equal to density. The density will be different with water and mercury. Acceleration due to gravity and height. Now you see this is a mercury manometer, it is pushed. This is normal. As soon as you put the pressure, it is flowing like this and we are measuring the pressure. For a manual system, ensure pressure in the cuff is released slowly, 2 millimeters per second to allow accurate measurement. The bladder of the cuff should be ultimately over the blade artery. The width of the cuff should cover 2/3 of the arm. The width of the cuff should cover 2/3 of the arm. The width of the cuff's bladder should be 40% of the circumference of the arm. Here it is 2/3. Here is circumference is 40%. The bladder should sit exactly at the brachial artery. All these things should be necessary. To understand clearly, now you see, we need to have a proper cuff. See, this is connected to the measurement. Now this cuff pressure blocks blood flow. Now you are releasing. Here we are releasing. Now you see, slowly the systolic blood pressure is coming. It is above the cuff pressure. Now you see, diastolic pressure is here. Korotkov's sounds. Cannot hear the pulse. Now the filter 1 here and filter 2 here, both can be clogged. Air can enter the column of mercury. An inflation bulb can get stuck. Many times it happens, stuck. It gets stuck, it doesn't come off. Then you have to remove this backward and then push it again. Okay, all these things can happen. in these type of manometers. What is Pascal's law? Pressure is transmitted undiminished in an enclosed static fluid. Static fluid, enclosed, it is enclosed. Now here, this is not dynamic fluid, mercury. This is enclosed in a chamber. Now the pressure is transmitted undiminished. It doesn't decrease. Now it transmitted undiminished. That is what is called Pascal's law. And it is the only metal that is liquid at room temperature. It expands and contracts evenly with temperature and pressure. The problem is mercury toxicity. It is the only metal which is liquid at room temperature. That is what we use. Now we are starting to use aneroid. Aneroid means without water. That is the meaning of aneroid. It consists of a gauge, either a capsule or bellows that expand or contract depending on the pressure meter. The size of the bellows here causes a pointer to rotate. There may be copper diaphragms, maybe there to sense the pressure changes. Now you see, this is the bellows. Now the pressure is applied. Now the size of the bellows here causes the pointer to go here and there. Or there may be a capsule which may expand and contract, and it may be in copper, and that is changed and reflecting here as 120, 130 and all. To meet the diastolic, there is no this thing. We have to get the Korotkoff sounds again. The only difference is pressure measurement by mercury or aneroid. It is not automatic oscillotonometry. We have to get the Korotkoff sounds by stethoscopes to know even in aneroid. Now we go to the automatic instruments. The main difference is here we have a microprocessor and a transducer. What does the microprocessor do? The microprocessor controls the inflation and deflation. We don't deflate 2 millimeter per second, all these things, nothing. It is automatically inflated 20 to 30 minutes above the previous systolic reading. The transducer senses pressure readings and accurately 2%. Previously, what they say is one Reckley-Lawson's method. There were two cuffs. Here we got to pressure, and this will go here, and this will come here, and it will sense. This is outdated now. Now we have only one cuff. Use the oscillometric method. Oscillometric methodology is what? Oscillations are diagnosed, picked up, and made into digital forms. It's based arterial wall oscillates. Now we are starting to deflate. The arterial wall gets the blood. It oscillates. That is picked up, and the amount of oscillation picked up with diastolic and systolic. Some pick up map and then extrapolate systolic and diastolic. That is called deflation method. Pick up systolic, that is inflation method. So when we find in a monitor systolic, diastolic map, everything is not measured. Map is measured and systolic and diastolic the computer says. That is deflation methods. Systolic is measured and it extrapolates all these things is inflation methods. So many times, many monitors, many oscillometers, many NIPP monitors don't measure all the things. Now the deflation starts. Cuff starts to deflate here and cuff empties here. Now the blood pressure in the cuff pressure stops. Arm blood flow is fine. This is what is the systolic and diastolic pressures in the deflation methods, and Doppler recorded over the body laterally. And it measures how. Here there are a lot of oscillations. No. Here 0.5 into SBP. Now I'll show. The peak is there. 0.5 into peak is here. 0.8 into peak is here somewhere. This is the peak. 0.8 into peak is here. 0.5 into peak is here. This is the systolic pressure and this is the diastolic pressure of oscillations. Now there are two tubes is not there, single tube is there. Now there is a lot of doubt because some of the hospitals just say the normal BP mercury cuff and then it is unconnected to the SC. Sensing cuff is inside the machine. So cuff has got not much of sensors. Yes, we can do. The problem is we see the cuff here so compliant and see the cuff here that much not compliant. So we need good compliance as sensors. Now, previously we had two tubes. One is inflation and another is into the stings. Now you see the cuff has got only one tube. There are two tubes here, one and two. Now we have only one tube. Now there is only one tube. Now the cuff is exactly finely tied, but slightly lateral here. Now if you see the cuff is slightly down here, we cannot say what is the BP now, correctly measured. Device battery is important. If the battery is down, BP is not correct. Check to be plug is secured, pull the arm tighter. If the cuff is leaking, replace. Not to test cuff, that is very important. Is deflating because it depends upon small oscillometric fluctuations within the brachial artery. Now, if you do like this, in the cuff is doing, you do this, somebody injects something and somebody touches, puts a pressure on the ventral arm. All these things will change the pressure readings or so-called oscillations. So don't touch the hand at the time of BP measurement. Now there are two things, continuous, non-invasive. One is synapse, another is radial artery compression. What is the basic physics inside? Oh, it will go this. Synapse is based on Pinar's principles. Pinar's principle states that force exerted by the body can be determined by measuring an opposing force that prevents physical disruption. Now there is a body like this. Okay. Now you are giving a force like this. If it disrupts like this, then if there is some other force, it prevents disruption. Then it is the exact case. Pinar's principle, a force exerted by the body can be determined by a measure. Now this is the force. We are introducing another force. There is no disruption. Physically, the membrane is there, but here gone. Here it is gone. Here it's showing more pressure here, more less pressure here. So it becomes like this order. This is physical disruption. There is no physical disruption, then this force is equal to that force. That is called the Pinar's principle. That is what is used in FINAPRES, non-invasive, continuous BP monitors. Now we can see this is the FINAPRES, continuous, non-invasive monitors. There is something called applanation tonometry. It's based on Imbert-Fick principle. That is the physics. Pressure is equal to force divided by area. Now, that is tonometry is usually used to determine IOP, intraocular pressure by the ophthalmologist. Now we are doing this as compression sensor. Now we are compressing something and then we are finding out. Applanation tonometry is the principle is like this. Now we have pressure and actually we are finding out this thing. Radial artery, apply pressure, applying arterial pressure sensors, and we are finding out the pressure. Is applanation? Yes, reliable even in morbidly obese patients. The FINAPRES, reliable between consecutive permit detection of 5% changes, 7 to 8. Error appear to increase exercise intensity of heart rate and math. Age matters. This is what we are told. Sometimes precision and accuracy of NIBP monitors recording compared to the invasive arterial pressure. Honestly, what we have found out is the oscillometric pressure recordings by an automatic device are closer to manual BP in normotensives. Some difference in hypertensives. That is why sometimes we may be very cautious in first-time hypertensives with automated machines. This is what we have found out, Dr.S.Parthasarathy. Many times we talk about genetics, genomics, but see the cuff is above the arm, sit rightly in the chair, legs should not be crossed, arm resting at the heart level, the pressure gauge is like this. All this should be made when you measure a BP. Check your BP regularly, that is very important. But there is one more thing which is important. Check your BP apparatus also regularly. So thank you very much. Blood pressure is the lateral flows. Pressure is equal to TPR. Wind-Kessel effect is the elasticity. Compliance is delta P, B delta V. Voltage is equal to in resistance into flow, mercury and sphygmomanometers. Aneroid means there is a bellow which changes. NIBP, and curve is important, is with compliant curves. And non-invasive blood pressure monitors works by oscillometric methods. Non-invasive continuous with by either Penna's principle or applanation tonometry. Thank you very much. Visit my website www.painfreepartha.com and my YouTube channel Pain Free Partha.